Hello everybody, I'm Roger Kirby, I'm the current president. I think we may have a few other people drifting in, but I think we'll get going because we've got lots to talk about. So I'm the current president of the RSM. My successor, Professor Jill Lang, is around and she'll be taking over from me in July. So this is the third masterclass we've had on neuropathies, and tonight we're going to talk about diabetic neuropathy. About every other patient with diabetes ends up with a peripheral neuropathy, which impacts their mobility, causes chronic pain and increases the risk of infection and other complications, ulcers, etc., and costs the NHS about £250 million per year. So it's a big problem. So first thing to say is thank you, Alan Diamond, and his very charming partner. Alan can't be with us tonight, but I hope he's tuning in online. I think he thought it was starting at 7 o'clock, but you've given him the correct info. We'll still be going at 7, but Alan and Sheila Diamond Charitable Trust are responsible for this evening, and they've made it free, which all our RSM members are always saying, Roger, can't you make everything free? We much prefer not to pay any money for anything. But of course, we need to keep this show on the roads, and it's not cheap to keep this big building going. So the trust funding compliments grants is made to the University College of Osteopathy, and we'll be hearing from osteopaths today. Sheila sadly passed away in November 2022. We're very sorry Alan isn't here, but thank you again for your support. So I'm going to hand over to somebody who knows a lot more about diabetic neuropathy than me, which is not saying a great deal. I don't know much. I'm a prostate surgeon. That's what I know about. And Jonathan is going to introduce our 4 fantastic speakers, the Fantastic Four, I suppose you could call them, from the Marvel comics. Prashanth Vas, Fatima Kasim, David Hernschultz-Schmidt. I've been practicing pronouncing that name, and Julia Hubbard. But Jonathan, it's your show, and if you could try and finish at 8 o'clock, and just as a safety warning, if there is a fire alarm, then you've got to get out through that way or that way, because we're not expecting any practice. If the alarm goes off, it means there's a fire, but we haven't had a fire here for many years, so should be fun. Okay, over to you, Jonathan.
It's your show.
Thank you very much, Roger. I did remind Roger that he taught me when I was a medical student in the 1980s. And lovely to be here, and so many familiar faces in the audience, actually, including my mentor over many years as a junior, Robert Elkleys, is in the audience, so how lovely. Welcome, everybody. So let's enjoy ourselves over the next 2 hours. We have I think the plan is for us each to give a little sort of self-intro. So perhaps I'll go first and then introduce Julia, who's going to give the first keynote, I think. True? I can't see, I'm dazzled. Where's Julia? There you are. Then David, who will give the second. So I'll just give you a little bit about myself, and then perhaps I'll introduce the 2 main keynotes, and then each member of the panel will give a little self-intro, each of whom I know quite well, actually. So from my personal perspective, I think all of us here, speaking in some shape or form, have spent probably quite a significant proportion of our careers dealing with peripheral neuropathy. I set up a multidisciplinary foot clinic at St Mary's Hospital with Robert Elkleys, actually, back in, I think, 2001, Robert, we set up. So that was 23 years ago, and have spent a large part of my working life supporting people with diabetic foot disease. And I know that everyone else who's speaking in some shape or form has a similar story to tell this evening, with slight variations on the theme. Just to give you a little bit more background about myself, I'm a consultant diabetologist by trade. I'm currently Professor of Medicine based at Chelsea and Westminster Hospital, so part of Imperial College London. But I did spend, for my sins, 10.5 years as the National Clinical Director for Diabetes and Obesity at NHS England. So do have a sort of diabetes and peripheral neuropathy population health hat as well. So hopefully we can spice up the discussions with some different angles, and I can challenge Fatima and Prash and everybody with some thoughts on the population level as well. Now, an important topic. Am I right in saying we're about, in the next few years, to cross the 500 million threshold in terms of numbers of people across the globe with diabetes? And Roger's already alluded to the prevalence. We don't really know what proportion of that 500 million almost people have peripheral neuropathy, but certainly there are figures that suggest it may be somewhere around 40%, maybe even 50%. So for those of you who can do your sums, 40% of 500 million, I know is a lot. I think that's 200 million, isn't it? So, the disease burden around peripheral neuropathy related to diabetes is huge. And of course, while diabetes is the most common cause for us here in the UK, whether or not that's the case globally, I'm not so sure. And David, you'll be able to tell us where leprosy, for example, ranks on a global level in terms of whether the numbers of people suffering from peripheral neuropathy from leprosy, for example, outstrips the numbers with diabetes. So diabetes is just one cause, but that, of course, is the focus for this evening. So that's enough of me. Julia. Delighted to welcome Julia Hubbard, who brings a wealth of experience for our discussions today. So I think I'm right in saying that we have crossed paths before. And you're now with JDRF,
yes,
third sector organisation, who've been marvellous really in the type 1 diabetes space for many years and internationally. I'm right in saying you're head of research partnerships. That's there right, now. Yeah. Lovely. Now, Julia also has 20 years of research experience at GSK.
Yeah.
Okay, I do have a crib sheet for that.
Program leader at GSK for 25 years.
And also offers a unique perspective as someone living with type 1 diabetes. I think I'm allowed to say that, am I?
You can. I'm going to be talking a lot about my medical sort of experience and journey into neuropathy. So
look forward to it, and that'll be a fascinating angle and insight for us all. So thank you. Julia, I'm going to hand over to you.
Thank you. Should I go here or here? I mean, I'm quite happy to just chat from the chair.
Yeah,
if that's okay.
I've
got a few notes.
In that case, I'll sit with you.
Thank you. I've got a few notes that I'm going to refer to along the way because I'll be quite open. I was only asked to do this yesterday. So with work, it was trying to put something together in a pathway. But basically, what I'd like to tell you about, and tell me if I go on, please.
We don't mind.
But, well, it was here at 9. Okay, so everybody's journey is different, as you know, and everybody's experience, I think, of conditions is different. So I'm just going to tell you very much about my personal experience and the effects of getting diabetes and getting complications on not just myself, but on my family, particularly my children. I have 2 now grown-up children who have lived with me having diabetes for the whole of their life. And my family, my friends, and even, actually, I'm going to touch on work because it's had quite a big impact on work throughout my career. So I'd also like to say that just if I do say anything that may come over, nothing's actually meant of criticism of anything else. Getting diagnosis and getting the right treatments and all this sort of thing, it's really, really complicated. So in some ways I was really lucky. I was diagnosed with, well, not lucky in being diagnosed with type 1, but often for people that have a diagnosis of type 1, it comes with a real drama. You know, it's completely out of the blue and they end up in intensive care and A&E and, you know, it's a real problem for families. But I had an uncle who was type 1, so I'd lived with that for a lot of my life. So when I couldn't get down the end of the garden without taking a drink, and then a few days later, I'd been swimming a lot, I got in the swimming pool and I couldn't get to the end of the pool without feeling I needed a rest. kind of thought something might be wrong. Can I borrow your blood glucose testing kit? Yeah, okay, so we've hit on it straight away. That was type 1. Went to the GP. GP said, going to need to send you to hospital. I was still really, really lucky in that stage of my life. It was, so where is that? You know, now of course I know because I'm there a lot. I'm still there a lot. So I had type 1. I was lucky enough to be building up a career in the pharmaceutical industry where I was actually working on diabetes, but not type 1. I had 2 children, very, very busy, as you can imagine. And my first brush with neuropathy was in around 2009. Things had been really, really busy, and I felt that maybe things were getting on top of me. But I started having problems with fainting and trouble eating. I was really, really sweaty every time I ate. This sort of almost like passing out was clearly not due to hypoglycemia. I was really weak, my heart would rush, I had low blood pressure. So an appointment at King's, which is where my specialist care is, and they have always been fantastic, my consultant said, oh, I'm a little worried that maybe this is autonomic neuropathy. Let's send you for some tests. Quick Google, what's autonomic neuropathy? Yeah, okay, it kind of fits, but I don't like it. So I went through that series of nerve induction tests, tilt tables, standing with my eyes closed, ECGs, all this sort of thing. And when I saw a neurologist to put all this picture together, he noticed at the time, oh, you've got really quite extreme joint hypermobility, haven't you? I don't think this is diabetic neuropathy. I think you've got a condition called POTS, postural tachycardia syndrome. And I was given some medicine to go away and start managing that condition, which actually worked really well, but it was just adding some more medicines. It had been actually a really troubling time because you can imagine my children were quite young at the time, and to have a mum that's going through that, plus actually the exhaustion, fatigue, and I was in pain the whole time. I think that was quite difficult. And at one stage, my daughter ran away. And it made me realise the impact it was having on those around me, which, as a mum, I'm sure everyone can understand, you care more about that than you care about your own health at the time. But anyway, so I recovered from that. Back we got going again. This time I was still on a cocktail of painkillers and things like this. And then around 2011, I started getting ill again. And when I say ill, I had to be off work. I was actually off work for maybe getting on for 6 months. The company I was working for at the time were actually really supportive. But the occupational health medic again thought, this is what happens to people with diabetes over a period of time. They gradually go downhill, and I see this. But I had rashes. I still had the joint pain I'd had for a long time. I had problems controlling my blood glucose. It was really, really having periods of going up and down. And we thought, or what the impression I was getting was from the medics around me that the pain was caused by the aberrant blood glucose and the inflammation and the tiredness and fatigue, not potentially another way round. Again, I was really lucky to see a consultant saying, well, the problem is once you've got diabetes, we always tend to think that maybe the things you've got are because you've got diabetes. We don't really look elsewhere. That ended up with my diagnosis of lupus, which when they looked back on all the medical records from the past, you could tell the signals were always there. It's just nobody had put that together. So then I ended up on some more drugs. So I take quite a cocktail by now, you know, and I'm aware that, you know, sort of like the numbness, the tingling, it's just like part of, you know, almost everyday life really, but I managed to carry on working, that was fine. Then in 2013, having dinner with some friends when we were on holiday, I got up from the table, suddenly had no feeling in my leg whatsoever and just fell over, completely collapsed under me. Again, they did a whole load of neuropathy testing and said, you know, the signalling's just really not right in that leg. And actually, this time, we don't know why. So I had 2 years, really, when I was on crutches. I'd always been very keen on sport, so I finally accepted this was maybe how it was going to be. So I started playing wheelchair tennis. I thought, you just got to try and be positive with this and this outlook. But I did end up again on another therapy program that, as you see, has got me walking, so I'm very lucky. So where are we now? I would say that for me, I'm in pain all the time, really. I'm always taking painkillers. I take paracetamol. If I'm lucky, that's the only thing I take for pain during the day. I'm on very high levels of pregabalin, which is actually where I wanted to mention the job. Because when I first went on this, it was a game changer for things. A lot of my peripheral symptoms were really going away. My energy levels were going up. But I felt I was working as an attorney at the time. I was muddling my words. I really wasn't able to get sentences out. And I went and saw my very lovely consultant here and said, so this drug then, I think this is a side effect. Am I going to get used to this? The side effect's going to go away? And he's a very real guy. And he turned around and said, no, I think people just get used to it. And I think that's true. I don't think that's gone away. I've never got that ability back the whole time I stay on this drug and as I'm on escalating doses. And that job didn't last a lot longer. I just felt I wasn't really properly functional in that area. So I left a career I'd loved for many years and actually went back to academia. Not saying that it was just a different pace. So my journey's different. Things are still progressing for me. I think I've coped. I think I've coped because of a huge amount of support around me. And I know it's not the same for everyone else. Other people's conditions progress faster. They end up in a worse position. I don't know where I'm going, but I do see how for clinicians as well, making that diagnosis of this is diabetic versus something else is not straightforward either. So it's a big team effort to try and support us and keep us going. And of course, the one thing I'm always extremely grateful to is the research community that found insulin in the first place and pumps, but actually that, you know, are working on novel pain medications and potentially trying to slow down progression of these sorts of things. So it's not going to be the same for everybody else. That's me done, really. If anyone's got any questions, you're really welcome to ask, of course.
That's excellent, actually. Yeah. My question is, you didn't mention your glycemic control over time.
Yeah. It's, you know, I think what we're asked to achieve varies for different patients. Yeah, and because I had a lot of erraticness, I was set at, let's try and go for 8%. Yeah, and we'd rather, as an HbA1c, we'd rather you stayed there and we tried to get a little bit than constantly bounce around with the hypos I would get if I tried to run lower. Now, I've tried closed loop. That doesn't work for me at all. Sensors don't work for me. They misread. We think that might be due to some of the drugs I'm on, but we've tried an exclusion diet. We can't find out what it is. Personally, I think there may be other factors that are peripheral involved in that because I don't think I'm the only one. So I've hovered mostly around the 8% for most of my life, but every day I will vary between 3 and 20 something. And it's that dramatic.
Yeah.
You mentioned you got this pain. Is the pain mainly in the joints or anywhere else in the body?
So it varies. When I say it varies, a lot of the time I will wake up in pain and I'll wake up in pain and it's all over. Sort of all over, so my skin feels like it's sunburnt from my sort of elbows down and my feet down. I've got a bit on my foot I can't feel, but I still get I perceive it as muscular pain, and I still get joint pain. So I think there's sort of almost like different sorts of pains like that, if you see what I mean.
Julia, did I see another hand? No? Okay, just stretching. Thank you, superb insights. You've already covered a lot there of the most topical areas, not just around neuropathy, and you've got in autonomic neuropathy, which often isn't top of the pops in terms of clinicians' thoughts. You've covered peripheral neuropathy, and I think you've covered something else which is crucially important. And Fatima's smiling because we've worked together in the same foot clinic for, I don't know, a decade. So she knows what I'm going to say. But we shouldn't always be assuming, oh, someone with diabetes, a neuropathy, it's due to the diabetes. And I think that's a really important feature. From a clinical perspective, I often find it useful to match the degree of retinopathy to see if it matches the degree of neuropathy. And if the neuropathy is more than one feels one should be expecting from the degree of retinopathy, I start looking for other causes. So,
that's really
so
interesting.
you've covered something really important. And I think the final area that you've covered, which is also the clinical reality for us lot that are clinicians and the living reality for people with long-term conditions, is that, where are we now? 3.5 to 4 million people in England with diabetes, 285,000 with type 1. What does that make? 3.67 million with type 2. And a frightening proportion of those people have more than one condition. And what we're now sort of coining the phrase multi-morbidity or multiple long-term conditions. And sometimes they're linked, type 1, and that sort of autoimmune umbrella. And sometimes they're not linked. But that is the clinical reality of what we see. And I think many people living with diabetes are experiencing as well. So what a masterclass as an opening. Thank you. David, you're up to bat. Please do.
Should I stay here? I'll go
No, stay. Can I give a little intro to you, David, before you kick off? So, David, now I'm going to do my best at pronunciation. Hohenschmidt. How did I do?
Thank you.
I've had practice though, haven't I? Because we've been crossing paths for a little while too. So David, I crossed paths with in my new life at Chelsea and Westminster Hospital, which started only 6 months ago, actually. I think that's when we first crossed paths. Now, for me, peripheral neuropathy, diabetes, the most important consequence in terms of what I see as a clinician is more painless, but the lack of pain is an affliction. And we need pain to let us know when something's going amiss, because when you don't feel pain and you have a stone in your shoe and you're not aware of it, you get a hole in your foot. And so diabetes is the commonest cause of limb loss, actually. And I'm going to hazard, well, I've seen data to suggest that this is the case, that probably the most feared complication of diabetes is, would that be match what's in your brain or not?
I think it's between that and eyes.
Yeah, fair enough. But it is certainly a feared complication. David has opened my eyes more, despite 23 years of my own clinical experience, the importance of the pain component, actually, and that I think, Julie, you've alluded to this, that a lot of the treatments for painful neuropathy aren't perfect. And so clinicians tend to gravitate towards things that they're good at doing things about. And we've got quite good at dealing with foot ulcers in foot clinics, but probably less good at dealing with the pain. And I know you've invested a significant proportion of your time in painful neuropathy, and I hope you're going to touch on that in your talk. David's based at Imperial College London. You've worked with Andrew Rice, who I think chaired the first of these 3 masterclasses for a number of years, and you did your PhD
with him
back in the day with Andrew. And you also serve as a senior research fellow at the University College of Osteopathy. David, over to you.
Thank you very much.
That was a long, winding intro, wasn't it?
It's good. Yeah, not so long ago. The PhD was last year that I graduated. And I've come into that field really from more of a musculoskeletal background. My clinical background is in osteopathy. And then I did a PhD mainly focusing on clinical trial methods of non-pharmacological treatments, which I spoke about last year. And then we moved into the area of diabetic neuropathy and specifically painful diabetic neuropathy, which we can probably discuss a little bit later on, but is a considerable proportion or affects a considerable proportion of people with diabetic neuropathy. And before I start, I'd like to thank the organizers, but I'd also like to thank the Alan and Sheila Diamond Charitable Trust for supporting both my PhD as well as the postdoctoral project that I'll be talking about right now. This is really a bit of a pitch of an ongoing or upstarting research project, which involves a feasibility trial of an intervention that I, together with a group of researchers, clinicians, and patient partners, have developed. And it's really aimed at putting osteopaths into the position to work safely and effectively, hopefully at some point, with people with painful diabetic neuropathy. Well, I think it's good practice to touch on that briefly. I think my main conflict of interest is that I am an osteopath, so I might have an interest in the standing of that profession. Everything else I don't think is particularly related, but my colleagues will also say that I'm a critical osteopath, hopefully. And I want to start here as well with the perspective of people who live with painful, in that case, diabetic neuropathy. And I'd like to thank Julia again for her very personal and really insightful presentation. We asked people as well what it was like to live with that, and I've sort of triangulated that a little bit with the literature. And you do hear about considerable impact on function as well as on sort of emotional and social well-being, often involving physical activity, whether that's due to the pain itself or due to balance issues or the fear of ulcerations developing, an effect on sleep, either from neuropathic symptoms like paresthesia, so tingling, numbness, or the burning pain often at night, an impact on mental health, of course, and a direct or indirect socioeconomic impact. Also talking to patients, they often voice that certain dissatisfaction with their available care, the things that they had available, mainly involving drug therapy, as we heard, and we know from big meta-analyses that it takes sort of treating up to 4 or 5 people to find one where that leads to pain reduction. And often we hear that some of the side effects can be almost prohibitive to take in the medication. For example, I've spoken to someone who said, well, I don't sleep at night because of the pain, and then the medication makes me drowsy. That doesn't, it just aggravates the symptoms that people have in some cases. So there's this starting point from saying, well, the medications that we have certainly are, like you said, there's scope for improvement. My background is not pharmacology, otherwise I'd probably be looking into that. Also considering that the pain field has undergone quite a bit of trouble with medications for all sorts of pain recently. So there is certainly a research interest in non-pharmacological treatments generally in the pain field, but looking at neuropathies is probably slightly newer. Talking to patients, but also from these interview studies, we know that some people know a lot about their condition. They know what it is about, how they can manage it, and some don't even have it diagnosed for a very long time, or sort of have never really been told what it is and what the consequences might be. So there was certainly a sense of desperation talking to those people, but also an element of hope that somebody was trying to develop new treatments. I have to say, at the very early stages of this, so I don't know if it's a promising approach at this stage. And something that's also come up with from the conversation with Julia is that other types of pain, such as musculoskeletal pain, back pain, peripheral joint pain, is up to twice as common in people who have diabetes. And from an osteopathic perspective, that's certainly interesting because that's the population that we often see, people with back pain, joint pain, headaches, etc. So starting from that background, we put together a group of researchers, clinicians, and said, well, what's the evidence for different types of non-pharmacological treatments? And well, let me tell you, there's not a lot currently, and it's not always particularly good, also because of the challenges of researching complex interventions. But we took what was there and put it together into a training program for qualified osteopaths. Maybe a couple of words on that profession. It's one of the allied health professions in the UK, probably comparable to sort of a physiotherapist, chiropractor. So it's a hands-on manual therapy that involves moving joints, massaging muscles, but also a lot of education, lifestyle advice, integrating exercise components, etc. And in particular, people in the UK are trained as primary or sort of first contact healthcare professionals, so they are trained to diagnose and to differentially diagnose and refer on, or recognize when they have to refer on, which I think is from a safety perspective an important thing. Now, this new OST treatment, as we called it, involves a couple of other elements. It involves a structured education around diabetes and neuropathy for the patients, a sort of routine complication screening, because when you see someone regularly, you can probably make it good practice to look out for complications. And then this manual therapy element, some exercises, both cardiovascular, so bringing up your heart rate, as well as stability, strengthening, and stretching type exercises. And also we worked with Dr. Whitney Scott, who's a clinical psychologist from King's, and what's called, we sort of used elements of some psychological approaches to enable people to look at their sort of pain-related thoughts and feelings in potentially a slightly different way. And all of this was put together as a 2-day training program. This is our first cohort that underwent this training in January, and 6-7 out of those have now gone on to become clinical trial providers, which is what I'll be talking to you about in the next couple of minutes. So we're doing a small feasibility trial, which is mainly asking whether we can conduct a larger clinical study or whether we can conduct a clinical trial at all. So we've gone from intervention development to now trying to see if we can study that, and if that treatment in itself is acceptable to patients, and if it can be delivered by the kind of professionals that we've selected and trained up for. So this study involves 3 groups. It's really small because it's only asking whether we can do a trial. It's not asking whether it's effective at this stage. And we split them into 3 groups. 2 of those are treatment groups. One is the new OST, and then there's a comparison treatment which looks similar but lacks a few ingredients that we're trying to study. And a 3rd group that doesn't get treatment as part of the study, but only continues with their normal, usually NHS care, because we have to have that sort of comparison as well. After those 5 treatment weeks, there's another episode of follow-up, so we're going to ask a few more clinical questions after the end of the treatment. And this is what it looks like as a diagram. So you start off with an assessment, and then either move into one of the 2 treatment groups in the blue box there, or you continue your usual care. The vision with that is, I think, a bit more broad than to ask whether osteopathy can work for something like painful diabetic neuropathy. At this stage, there's really big question mark there. But I think what the whole project aims to do is to raise awareness as well for other approaches to maybe early detection, as well as then an intervention that's not pharmacological potentially. So I want to learn more about this approach, about professionals and professions within the UK and within the NHS as well that can potentially deliver something like that. Eventually, we'd like to develop that further, either into maybe group therapy or something that can be delivered by other professions, and conduct a larger clinical study that can then actually ask, well, is this an effective treatment or not? And in the short term, we also hope that at the University College of Osteopathy, where the project is hosted, that's in Borough in South London, we can establish a community clinic where people from the area can come and try this or receive regular care from people who are from osteopaths who are trained in this therapy. And I also just want to briefly comment and thank the people who were involved in this project. It's a large endeavor involving, like I said, researchers, clinicians, as well as a patient or several patient partners. So with that, a shameless pitch to the study. It's just opened recruitment this week. So if you're interested, feel free to either contact me through the contact details there. I've got a couple of information leaflets. The flyers haven't been printed yet, or you can visit the website either through taking a photo of that or scanning that QR code or asking me later on. Yeah, and I look forward to the rest of the evening.
Thank you, David. Please come and have a seat. Julia, do you want to come back and join us? Well, how refreshing. What a very, very different angle compared to what many of us in clinical practice are used to. Marvellous angle, really, David. Julia, what do you make of such an angle? So,
I think it's really interesting.
Yeah.
It's really exciting, actually. It's it's never closed doors to new opportunities. But yeah, I'm going to look up your QR code. We should advertise it on our webpage as well. Yes.
Yeah. And Julie's alluded to, you've really driven home, which I completely endorse, which is that view that we have lots of different prescribable medications for painful diabetic neuropathy, and the reason we have so many different is because none of them work very well. And so I think a non-pharmaceutical angle is very welcome. I think from people with lived experience or experts by experience as well as us clinicians. So, okay, yes.
About these structures? Yeah, it really depends on the ability and the potentially the symptoms that individual patients have. I don't think there are anything that's prohibited or that shouldn't be done necessarily as a blanket, and it needs to be integrated, I think, in a both strengthening, stretching, stability kind of program. Actually, yeah. Yeah. Well, we haven't done much in terms of asking whether it helps yet. There is some research on exercises, and it seems to have a bit of an effect on stability. So feeling a bit more safe, but also being measurably a little bit more stable on someone's feet. But these are often quite intensive programs, and we're trying to establish something that sort of becomes routine for people. One thing that in the development of this came about was really that we need to adapt it to the abilities of the person and their potentially concerns as well. So we're talking about how can we make it safe to exercise if you're feeling wobbly on your feet. How can we adapt stretches or strengthening exercises to what you can do, remembering that's quite a broad spectrum of age, ability, comorbidities, other diseases as well. Yeah.
Robert.
Thank you very much. Could you explain a bit more what you actually mean by manual therapy?
Yeah. So manual therapy generally is treating someone with your hands. The techniques that will be involved in that are massage type techniques. So you're trying to relax muscles. Then there's joint movement. So one of the challenges I think in the manual therapy field is that there are conflicting theories of how it works, and then also some gaps on whether it works for different conditions. And for neuropathy, we certainly don't know, which is why we want to investigate it. But traditional models would explain something like you'd be more flexible afterwards, or you're trying to realign things. And I think we moved on from that point of view. Modern manual therapy seeks to explain it more along the ways of short-term pain relief and then using that to integrate into behavioral change potentially, so enabling people to do a little bit more for a short period of time, and building on that. Does that answer your question?
Yes.
Could you expand this along the psychological level?
Yeah. So the therapy we've worked with in particular is acceptance commitment therapy, which is sort of a third wave behavioral intervention. So there's cognitive behavioral therapy, which I'm not a psychologist, I have to be careful now, seeks to sort of change how you respond to what you, or seeks to change your thinking around your experience and then your behavior on the back of that. Acceptance and commitment therapy works a little bit more with elements of mindfulness, and yeah, I don't think I need to. I'm not qualified to go any further into any more detail. But we're not training osteopaths up to become psychologists. We're using some of the techniques to integrate into their management. So those would be things like goal setting, like using metaphors to look at your experience from a different angle. Yeah.
I do find it really interesting you say this, because all the things you've mentioned up there are things where personally I feel I put in to, you know, the regular stretching, because obviously I have balance issues, you know, worrying about falling. I broke an ankle because of falling early in the year. I find all those help, but the mindfulness particularly, I do Headspace every day, and it's about feeling that the pain is just like a noise. A lot of the time it's a noise that you try and sort of notice and then move on from. So I don't know whether that's similar to...
Yeah, I think that's sort of the stance that ACT as a therapy seeks to take, not necessarily changing things, but acknowledging it, but not letting yourself influence too much by it. So I think that resonates with what you're saying.
Roger.
Yeah, I'm just wondering whether, you know, osteopathy is a bit of a misnomer, isn't it now? But it sounds very skeletal, but you do so much more than work on the skeleton now. Maybe you ought to think about changing the name of your specialty. And the thing we were talking about before about continuity of care, and you were saying, I think that it's hard to see the same GP again and again and again, but what you're offering is that interpersonal relationship that people can relate to you because you've seen them again and again and again, and understanding their problem. Is that true? Is that the way you perceive it?
Yeah, two important points. I think the first is that osteopathy, like chiropractic and physiotherapy, is evolving. There's certainly tensions within those professions with people who adhere to more traditional models and others who seek to, you know, use tools from other areas and don't necessarily worry too much about what's classical osteopathy. I'll propose a name change. I don't think it will go down very well. And then on your second point, the therapeutic relationship and the ability to see someone regularly, I think that can be a very important ingredient of therapies. We know that a good therapeutic relationship makes a big difference, both from adherence point of view, so whether someone is able to actually incorporate some of the recommendations that are being made, but also from a context factor effect, so from placebo effect and your expectations that you develop. The downside, I think, with looking at therapies that are in the private space is that it excludes a big proportion of people who might otherwise be wanting to try this treatment. So that's certainly one of the things we need to work out, and the community clinic would be a subsidized approach. But then in developing that further, and that's something you've Jonathan's definitely reminded me of, taking this into the NHS seems a little bit unrealistic because of the costs and the scaling or lack of scaling effect. So that's something we'll be working on over the next few years.
There's a couple of more hands.
You've answered my question
Oh.
about making it available for the wider NHS.
Yeah.
Yes, please. Yeah. And I've seen you too. Please.
Thank you very much. I really appreciate it. Concerning your clinical trial, I have two questions. First of all, can you comment on inclusion and exclusion criteria? And also if you expect to treat people with low risk, moderate risk, or high risk?
High risk of what?
I'm so sorry, we can't hear anything else.
I repeat the question.
Can we perhaps use the mic?
Oh, yes. We forgot about the microphone.
Thank you very much.
Thank you.
My questions are about the clinical trial, and were, first of all, if you could comment on the inclusion and exclusion criteria to get the patients, and second of all, if you're going to treat, you expect to treat low risk, moderate risk, or high risk patients in terms of the clinical picture. Thank you.
Yeah, thank you. So the main inclusion criteria are diabetes, neuropathy as diagnosed with a simple questionnaire, and neuropathic pain. So that's another specific questionnaire. There are a few other things, but that's sort of the main population that we're looking at. We exclude at this stage people with amputations because of safety concerns and of sort of feasibility concerns. So whether some of that treatment is possible. Active ulcerations at the stage of inclusion would be something we'd be excluding at the moment. Yeah, and then in terms of risk, if I understand you correctly, risk in terms of sort of disease complications, or
yes, and also symptoms. Somebody without symptoms may be quite difficult for somebody with
Very mild symptoms. If you're going to clump them all together in the same sample,
Yeah.
you may not find anything at the end of the day, unless, because with these numbers you cannot define subgroups.
Yeah.
That was my curiosity, basically. Thank you very much.
So we don't, often in pain trials, you have a minimum level of pain, if that's your primary outcome. So you would say you have to have at least 3 or 4 out of 10 in your pain intensity rating. At this stage, we haven't even decided a primary outcome measure yet. So we haven't excluded people with low neuropathic pain. They have to have some pain to obviously score as neuropathic pain. So we won't have symptom-free people. Another project we're hopefully going to be doing in the next year or so is to look across the spectrum of people even before diagnosis or undiagnosed neuropathy, all the way to late stage and after complications, and see how patient priorities change there. But in this trial,
David was just awarded a grant to do that work a couple of weeks ago, so congratulations on that.
Thank you.
I did see one more hand.
I was just going to ask, there's like 5 different things. There was like 5 things you were doing, so it was like manual therapy, stretching. Do you guys have any plan to determine the actual effect of each one, or is that more of a long-term thing?
Yeah, it's more of a package at this stage, and the way the trial is designed is also not going to enable us to say, well, it's this particular technique or it's only the manual therapy. That sort of more mechanistic question is something for later on. Yeah, we do try and be quite careful about documenting what actually happens in the individual session. So there's a protocol that needs to be followed and that needs to be checked. But at the moment, it's more about, well, can this big package make any difference?
Okay, great. Thank you, David. Thank you. We've had our 2 keynotes. Now we've got 2 other members of the panel who are going to come and join us. And if I can drag you both up, perhaps Fatima, you go first to give a little sort of self-intro, and Prash, if you then follow on.
Good evening, everyone. My name is Fatima Kassim. I'm a diabetes specialist podiatrist, and I work at Imperial College. So I'm largely a clinician, but I do have a special interest in both academia and research, and it's quite an honor to be here this evening. Thank you.
And I'm Prash Vaz. I'm a diabetologist, a bit like Jonathan. I work at King's College Hospital mainly, but I also spend some time doing the diabetic painful neuropathy clinic at St. Thomas's also now. So a bit around Southeast London, sort of spreading my wings. So both sides, thanks to Jonathan Valabji's previous fellow, who is now my consultant colleague, which has meant that I am allowed to do all this extra bit of work. But my research interest is actually small fiber neuropathy, early neuropathy in diabetes, and these small fibers mediate pain and temperature. And out of this has come my interest in neuropathic pain and neuropathic pain management, and setting up the neuropathic pain services at both these hospitals. But it started off very innocently, a bit to ask Julia's question, is, all these patients being referred to the services with pain, the question initially was not to manage the pain, but to understand what was driving the pain. Was it just pure diabetes related, or were there other contributors, and could we address those other contributors? That's how it started off 10 years ago. And that's where it has evolved into now.
Super, thanks, Prash. And Fatima, thank you as well. So having worked with Fatima for, I don't know, a decade, was that right? So if you were really stuck in foot clinic, you ask Fatima. Anyway, I've got a series of themes here, and I think we'll delve into very broad themes, and then we'll discuss as a panel the various themes. And then there's a dedicated sort of half hour at the end, which will very much be sort of interaction and questions and thoughts from the audience. And I gather we can also take some questions for people who are watching remotely on Slido, or am I right? No, on Slido. So some people may want to ask their question on Slido, but very happy if you want to stick your hand in the air and speak into the microphone as well. Have we got people online? Aha, thank you. So start proceedings by giving a brief outlook. What is diabetic neuropathy? Now, I think many of the clinicians will have a fairly clear idea of what it is, and many people with lived experience will as well. But maybe, shall I give a little bit of background, and then we'll open up for discussion. So diabetes, we've mentioned how prevalent it is, very, very common across the world. We have two major kinds, type 1, which is an autoimmune condition, and type 2, that is, the mechanism is quite complex, related to resistance to the action of insulin, and is associated with lifestyle factors such as gaining weight. The majority in the world with diabetes have type 2, but there's a good proportion. What should we say, Julia? 8%, shall we? JDRF representative, what do you want? What percentage? 8%?
I think it's probably slightly less.
Slightly less, yeah. I think you're probably right.
1 in 100.
Yeah. Well, of all people with diabetes, I mean, sorry.
Yeah. I think it's about 1%, isn't it? Somebody might know better than me.
So in the UK, it's 7%. But
depends on the country,
but that depends on the country, absolutely. And access to
equator,
insulin is crucial, because in countries where there is no access to insulin, people don't survive, unfortunately, which means the prevalence is not the same as it is in the UK across the globe, which is your point, I think, isn't it? If the body is bathed in glucose levels that are higher than they should be for a prolonged period of time, it can damage the small blood vessels, the capillaries that supply all of our organs. And while that affects capillaries equally right across the body and across the organs, it becomes manifest very obviously as disease in 3 main vascular beds: the eye, the kidney, and the foot, essentially, because of the damage, the damage to the blood vessels that supply the nerves. And the nerves most susceptible are the ones furthest from the command module. So hence, as the years go by, a neuropathy will start at the tips of the toe and symmetrically will ascend with time. Interestingly, about the height thing, so certainly people with a HIT, such as diabetes, who are taller, probably have a slightly higher risk. So quite what the mechanism, Prash will tell us, the mechanism for distance from the command module, but it is a truism. We think about 40% of people with diabetes have peripheral neuropathy. The major clinical impact that we see as clinicians and for the health service is the lack of pain, and pain is important as a warning sign. And I use that analogy, which I always use, which is you get a stone in your shoe and it hurts, and you do something, you stop and you take the stone out. But if you don't have pain or sensation of that stone, you take your shoe off at the end of the day and it's full of blood and there's a problem and the skin's broken. And so the major sort of concern that has the major impact probably on, well, I'd say the individual, because of the risk then of infection, because there's an ulcer. And if that infection isn't tackled, the infection gets worse and deeper, and we frequently see the three of us in practice from a diabetic foot clinic perspective that the infection can go really deep into the foot, and infection of bone is very, very common in the people that we're seeing in clinic, and unfortunately in some people that results in an amputation. Now, a little bit of population health. Having sat in the national role for 10.5 years, we are in a reasonably good situation. And I think the second point to cover, which I'll touch on a little bit, relates to early diagnosis and getting in there and making the diagnosis and picking things up early, is that as a country, England from 2003 had a major focus on diabetes. It created a national diabetes audit. It followed, which audits the adherence to national guidelines, NICE guidelines. At the same time, we introduced somewhere in the region of 100 million per year additional resource to our general practitioners, specifically for certain care delivery aspects to everyone on a GP's list with diabetes. And one of those processes is annually doing a foot check, which means checking for the presence of peripheral neuropathy and checking for the integrity of the blood flow into the foot. So as a country, we are a little different in that we've spent, that came in 2003-2004 financial year. So we've had 20 years of additional resource supporting general practice to screen for peripheral neuropathy in everyone with diabetes. Now, we, as part of that sort of financial package, the 100 million isn't all for the foot. It involves retinal screening. It involves checking sugar and blood pressure and kidney function every year in every person with diabetes. Now, some of those aspects of care are very well delivered to over 95% of people with diabetes across England every year, such as HbA1c check, blood pressure check. The two processes which do less well, I think for a number of reasons, not least because they're a little more cumbersome, and the latter one of interest tonight is much more time consuming, is the checking for protein in the urine, which involves asking the patient in some way to pee in a pot and send it to the laboratory, and the other one is the foot check. And you know, in a pressured clinical environment with, I think, 10-minute appointment slots in general practice, if someone takes 10 minutes to take their shoes and socks off and put them back on again, you know, obviously that's more difficult to deliver on. And so the rates of delivery of foot checks are significantly lower. I think they're in the region of around 65% of all people with diabetes. But that does mean annually, you know, a high proportion of people with diabetes are checked. Autonomic neuropathy is far more complicated to diagnose, as you well know, Julia, now, and you've explained beautifully. And so that doesn't form part of the screening. And so that's something I think that clinicians need to be more aware of. So I hope that gives a little background of the position in this country and the sort of pathophysiology of diabetes neuropathy. Discuss. Team, discuss. Prash, you're bursting to get in there.
I should start. In a way, I think you sort of got into the epidemiology very well. There is some good news, though, Jonathan, and to the audience here, because, and I was alluding to this earlier, I mean, historically, we've often argued how much of neuropathy is around. Is it 50%? Is it 80%? And it depends, you know, if you take a relatively young group of individuals with type 1 diabetes, very few will have neuropathy as such. And if you take a group of people with 70 years of type 1 diabetes, it might be very different. But data emerging from the Steno Diabetes Service, and they looked at Copenhagen, people with type 1 and type 2 diabetes from 1996, I think, till 2018 or 2020, roughly about 30 years of diabetes care. And they found that the incidence of neuropathy development is now showing a decrease in trend. In type 1 diabetes, I think it was 4 per 100 person years back in 96 for 40-year-old men, and it's come down to about, I think, 1.8 or something like that in 2018. So it's a significant improvement. And I think similarly in type 2 diabetes, but for 60-year-old men, I think it was 16 per 100 person years. It's now come down to 8. So significantly huge burden still. 8 is still a big number, but the investigators felt our improvement in diabetes care is driving that. But our improvement in diabetes care is also improving longevity. So we are going to see people coming to our clinics more frail with neuropathy and its downstream complications. So that's something for us to bear in mind. And like you said, very much, we look for peripheral neuropathy, and fascinatingly, we have 2 phenotypes we struggle with, isn't it? One is the painless phenotype, who can then reach such a degree of insensitivity that they come to Fatima with ulcers. And then we have the second phenotype, who often, in my experience, my neuropathic pain clinic individuals very infrequently ulcerate, but they have such huge pain. It's such a trick to manage them. So that it's a paradox. And when you look at the microscope for these people, either by doing skin biopsies or even simple nerve conduction studies without the microscope, often you cannot tell the difference between someone who has completely insensitive feet or someone who has severe painful neuropathy. And this is a challenge which we've appreciated now for 2 or 3 decades, but aren't even an inch closer to answering why that is happening. Can I ask you, Jonathan, in that sense, from your role as the National Clinical Director, and you've been responsible for significantly increasing funding both into the care processes but also into the diabetic foot services, have you noticed that in the decade long, from the epidemiology in terms of diabetes complications, in particular neuropathy, a similar feature like the sort of Danish experience, or is it a data that you would think is awaited to happen?
Yeah, good question. So the easiest thing to measure in diabetic foot disease is something that is coded beautifully in hospital records for every individual right across the country, and you know this, of course. And it's not the presence or absence of peripheral neuropathy, because peripheral neuropathy, and we'll get on to this, is actually quite difficult.
Correct.
Although we've been incentivizing and supporting general practice to do the screen, it's difficult to do, and you may not get the right answer from the screen. And that's an important point for neuropathy that I think we should discuss more. Are there better ways that we could use for better mechanisms, techniques that we can use for more accurate diagnosis? Retinal screening. Everyone with diabetes has a camera for taking photographs of the backs of the eye. It's very reliable, very reproducible, precise, accurate. Diagnosing peripheral neuropathy is none of those things. So we measure something else, which is a further downstream and somewhat catastrophic event, which is amputation. We've got perfect data across the whole country on amputation. Minor, which is below the ankle, essentially toe amputation, but what really affects individuals' lives is a major amputation, and so that's above the ankle, so usually a below-knee amputation. Now, over the decades, we have seen significant reduction in major amputations across England, such that the major amputation rate now across the country is one of the lowest internationally. So I think we have done reasonably well, but I'm going to go back to one of the earlier points. We've got quite good. We know, in fact, King's, one of your predecessors in charge of the King's unit, I think Mike Edmonds before you and Peter Watkins before Mike, I think, the multidisciplinary approach. So when I first started at St Mary's Hospital looking after people with diabetic foot disease, we'd have a podiatrist who would see the patient each week, 2 stories below Robert and I, who were practicing in outpatients 2 floors above. If we needed a vascular surgical opinion, we'd have to write to someone who'd give an appointment in 2 months' time. And same for all the different aspects. So you need vascular surgical input to look at the blood flow. You need infection advice from your microbiologists when you're treating with antibiotics. You need all kinds of expertise around wound care that Fatima is an expert on. And you offload, if you conduct weight away from the area of ulceration, it's much more likely to heal. Now, we don't put weight on a cut in our skin because it hurts like hell, but if you don't have pain, you just carry on walking. And the weight causes the ulcer to get bigger and not to heal. So we got, King's first described in 1986, the multidisciplinary approach. So you get everyone in the same room at the same time. Prash, his vascular surgeon, his podiatrist, orthotist to fashion offloading devices or fancy shoes to take weight away from the area of ulceration. Who else do you have? Microbiologist, orthopedic surgeon, you name it. And that was shown to halve at King's amputation rates by instituting that approach to care. And we then took that model and tried to implement it across the country. And I think by last year, we'd pretty much achieved universal coverage across all the trusts in England with that model of care, which means we've seen this drop in amputation rate, which is a great success. But we as clinicians like dealing with that because we've got good at it and we can get people healed. The pain is different, isn't it?
Absolutely.
And we're not very good at treating pain, and that's where Julia's experience sits personally, where David's unique approach, I think, to diabetic foot disease will focus. So this will be interesting. Perhaps you and I can sit back on this question, Julia, but let's ask the three. Personal experience, and I can guess who's going to say where the weighting is going to sit here, Julia. So give me the split of the two different, you described some people who have painless neuropathy and develop ulcers, and painful neuropathy that rarely ulcerate but have terrible problems with pain. Give me the percentage split.
Oh, I think the three of us will give you three different numbers.
That's why I've asked. Julia and I can sit and enjoy.
So, you don't mind if I go first?
No, you go.
In my clinic, for the painful group, coming to the painful neuropathy clinic, it's 100%. But I think outside, and I can only talk about the sort of data from literature. They say about 50% of people with more than 15 years of diabetes could have a type of neuropathy, and perhaps
so percentage split. Prash, you can't evade the question.
Percentage
so what percentage of those with peripheral neuropathy, diabetic peripheral neuropathy, what proportion are painful?
Oh,
what
yes.
proportion are painless?
I think it's a 80 to 85% painless and 20 to 15% painful neuropathy. That's
Thank you. I'm sorry to push you. Yeah. Even there we could see Prash hedging.
I'm just trying to.
Fatima, give us your split.
I was going to say that about 3/4 of the patients have painless neuropathy, and perhaps a quarter of, so if we're talking 75-25 sort of percent. However, with the painful perspective, there's one thing I do want to mention, is that we often think that patients who present with pain in the clinic, if they've got neuropathy, then it might actually be as a result of painful neuropathy, but we need to exclude whether it's ischemic pain, because often we tend to overlook that and we can often get caught out by that, or whether there's other causes of pain. And sometimes the way patients describe pain, because pain is so subjective, and depending on how much of time we invest into investigating what the pain is. So if you're seeing somebody quite regularly, their pain patterns might change, but also the way they describe the pain might not necessarily fit within the clinical scenario of what we're thinking is painful neuropathy. And I think that's when it's important that we actually think a little bit outside of the box and think whether this is true painful neuropathy or not, and something which you alluded to, is there something else that's causing the pain? And certainly in our area, one of the first things we would always exclude is ischemic pain. You know, we've got to make sure that that's not what the cause of pain is.
What a good point. Thank you, Fatima. So focusing almost exclusively so far on peripheral neuropathy, we haven't mentioned the other potential complication hit to the foot, which contributes importantly to diabetic foot disease, and that's the blood flow. And whereas neuropathy, peripheral neuropathy, is highly related to the level of glucose and the duration of exposure, so years since diagnosis, really important for peripheral neuropathy. Age is a much stronger determinant of compromise to blood flow. So as we all get older, the blood flow to heart, to feet gets compromised, and our big blood vessels narrow. And as Prash has already alluded to, great success in recent years, increased longevity of actually the general population, but even more so the population with diabetes across the country. But it means we've got older people, and that means you'll have a bigger contribution to problems with blood flow. And blood flow problems to the foot of their own right can cause symptoms and problems and pain. Thank you, Fatima.
I just wanted to make, I think you absolutely, both make a very important point, and mine is not a counterpoint, but the real challenge in the frontline foot clinics is the huge amount of vascular or ischemic burden that we see. And deeply worryingly, because of the neuropathy, they often don't mount an element of pain. So they present to us late. And of course, that is also another big challenge, which complicates the overlay of vascular disease and neuropathy as the two interact among each other. We've got caught out. I mean, everybody gets caught out with this scenario because of delayed referral. But one of the dangers of having a neuropathic pain clinic with its 2 or 3 month waiting list is missing on a vascular pain if they get in. And I'll come back to that if you ever. That's why I like doing that through the foot clinic, because everyone gets their vascular assessment first, their biomechanical assessment first, and then you're left with a neuropathic pain individual. Then we can start thinking about what to do next, and that is perhaps the best way we've sort of figured out at King's to work around managing neuropathic pain.
Yeah. Thank you.
Can I add a question to that?
Sorry about that.
You've got more than a question. You've got to answer. Give us your percentages.
The first thing I noticed was that I look at the percentage from the different perspective, the other side. So while you were talking about 75% pain-free, I always paid attention to 25 painful. But I've seen that number fluctuate depending on the publication between 10 and 60%. But I think
10 and 60.
I think I've seen somewhere they said 60, but it then depends on.
And that's
on
the direction
population.
I was anticipating you may point us towards.
A bit more further.
Yeah,
no,
because
I think if I write about it, I'd probably settle for the 25% as an average.
Oh, well, we've done well. We've got some consensus there. Then I wasn't quite expecting that, so that's good news.
Well, the real number's probably different, isn't it?
Say again.
The real number's probably different to that.
Fair enough.
It changes because Riaz Malik's data from Manchester is approximately 20%, but his data from Doha, Qatar, for painful neuropathy is closer to 40% in his cohort. I don't know why that is, but I suspect there are cultural and many subjective sort of things complicating perception of pain and therefore reporting of pain.
How interesting.
Yeah.
David, you had another point.
Yeah, that would have been my thing to maybe discuss. How do you then differentiate vascular pain from neuropathic pain? I know the definition of neuropathic pain to be pain that has certain qualities or is associated with potentially nerve function loss in other areas, so numbness or paresthesias or burning qualities, and also in an area that is anatomically plausible, which makes a bit of a problem in peripheral diabetic neuropathy, because it could be both sides and coming up from distal to proximal. How would you distinguish that from vascular related pain? Would that be non-symmetrical or?
Sometimes non-symmetrical, unilateral presumably. We can feel for pulses, and if you don't feel pulses, I think it's very important then to get a vascular scan. But in reality, once they come to the high-end clinics, ours, Mary's, Tommy's, we will get a detailed vascular scan to make sure there isn't significant vascular issues complicating the scenario. So I think that would be done. But as a minimum, if someone's referred to a hospital with sort of lower limb pain and has diabetes, and you suspect there is diabetic neuropathy as a differential, we would work up at least a Doppler waveform to make sure there is a good pulse and we're not missing on ischemic pain. In an individual with poor pulses, we will definitely do that. And that would allow you to exclude vascular element and leave the neuropathic element.
So also patients who present with ischemic pain have symptoms, so they might, besides the fact that they'll have skin changes, they might have cooler limbs, they might have a paler limb, they might also complain about intermittent claudication, so that's calf cramping or cramping in the bottom of the foot, which may relieve after, so they can only walk a short distance and then they've got to stop and then, massage their calf and then maybe walk a short distance, and that distance that they're able to walk actually gets less as the circulation gets worse, or they might actually complain of rest pain, and obviously in some instances where they actually have tissue loss, but before they actually get to the time where they actually develop tissue loss, it's about picking up the initial symptoms that they might complain about. So that initial vascular assessment is really important. So checking, skin integrity, temperature, the pulses, whether they've got a good capillary refill time. So it's just actually looking. Looking is such an important thing in terms of clinical assessment, because when you look at something and you observe something, it gives you so many clinical clues, and then obviously your diagnostic investigations will then lead to, and your assessment will then lead you down a direction. But as Prash says, we're actually really fortunate because we get vascular scans really quickly for our patients. So the moment we pick up something, we can get that sorted out very quickly.
So poor blood flow into the foot can be a major inhibitor of an ulcer healing. And the guys have given you classical symptoms and signs to point us in the direction of the blood flow needing to be dealt with. And our vascular surgeons can do some plumbing for us. They can either stick a balloon into a narrowing in a blood vessel and open it up, or they can do some even fancier plumbing with their knives and forks at operation. So actually doing what you call bypass surgery. But actually it's often not that easy, is it? And sometimes we don't realise that ischemia is a major contributor, and then we realise, well, we've been going 6 months and the thing still hasn't healed, why not? Oh, is it because we need to deal with that, what looked to be a non-significant narrowing? Maybe it is significant, and you treat the narrowing with a balloon and the ulcer heals. So it can be very variable and not so clinically obvious in some patients. Is that fair, Fatima?
Yeah, it is, and I think...
If in doubt, ask Fatima.
No, but I think what needs to be qualified is that any procedure comes with risk. And often, even in as much as an angioplasty sounds really easy or sounds quite, simple, there is a certain degree of risk involved with it. So I think in terms of whether somebody ends up going towards having the angioplasty is a very balanced and considered clinical decision. And I think that's where that multidisciplinary approach into the decision making actually is very important. So it's not, so sometimes, you'll get the scans early on, but we kind of maybe want to give it a little bit of time and see what happens, depending if, especially on Doppler waveforms, they're not the worst signals.
Okay. We'll spend another 10 minutes or so with panel discussions, but I haven't got very far through our list, it has to be said. But there's a point about prevention, and I'm going to medicalise that, and I'm going to get Prash to give a summary of what you consider the important aspects of prevention. But then the next point, I think, is much broader for all the panel. New developments. What new developments do we need, maybe around diagnostics, and what new developments maybe just around the corner? And Julia, maybe you have a JDRF perspective, maybe you don't, but I will ask you anyway. But let's get Prash, fire away. How do we prevent peripheral neuropathy in people with diabetes?
I think this is a difficult question, really. I think that's a multi-billion-dollar question. I think there is a difference.
You've got a minute and a half.
Yeah, there's a difference. I think there's a difference between the neuropathies of type 1 and type 2. And at the moment, from the data that we have from good clinical studies, distilling them together, both for autonomic and somatic neuropathy, in type 1 diabetes, good diabetes control equates to delay in development and delay in progression, even if it is developed, of diabetic neuropathy. And this is very early neuropathy and its progression. Whereas in type 2 diabetes, the data isn't very strong. And it's felt that the reason of type 1 diabetes, and still not clarified, is predominantly a microvascular phenomenon, whereas in type 2 diabetes, at least in the onset, it may be a significant metabolic phenomenon as much as it is latterly a metabolic and a microvascular phenomenon.
So if it's not glucose in type 2, what is it?
So the feeling is that the other two big players are equally important, blood pressure and dyslipidemia. Sometimes equally important or more important than just glucose in type 2 diabetes.
And which element of the dyslipidemia?
Well, the link, strongest link is with hypertriglyceridemia rather than, say, LDL cholesterol. But the way I sort of say it is, the typical cardiovascular risk factors are the same risk factors that drive neuropathy. And of course, they are the same risk factors that drive sort of nephropathy of diabetes. So it's looking at that sort of element. There isn't a drug that has been shown to disease modify, like we have biological agents in, say, rheumatoid arthritis or even asthma now. We don't have one. They've tried a few agents. They are all those reductase inhibitors. There are 4 or 5 of them. They've tried a few of them, but none of them have shown improvement enough to be sort of clinically usable. So most of the work is about good optimization of diabetes, blood pressure, lipids, and now all that classical stuff that we all do. There is some evidence to suggest supplements may help. Antioxidants like alpha lipoic acid has been shown to improve. The data is for intravenous alpha lipoic acid. The challenge is all the studies on this agent have been done by one company sponsoring all of them in 12 papers from Germany. But there is some sort of a consensus that it may benefit, but it's not MHRA approved, it's not FDA approved. There's also benfotiamine and certain other supplements are emerging as options for diabetic neuropathy. For neuropathic pain, it's slightly more different. We're still using neuromodulation as drugs to calm the nerves down, directly down there, but they will go all over. So it's mainly pregabalin will work on your brain as much as it'll work on your thing. But NICE is now increasingly interested in non-pharmacological modulation. And so we're doing a study looking at non-pharmacological electrical stimulation. You are doing, with Sasha Smith, I think, a similar study at Imperial. And also, the biggest thing in neuropathic pain has been the emergence of neurostimulation, implantable leads into the spine. A very large, very, very good study from America showing benefits.
Sheffield.
Sheffield did this 10, 15 years ago, 12 patients, Lancet paper. But this is 260 patients, high frequency, that was low frequency, very modern neuromodulation, showing it's safe to do because people who shied away from doing diabetics because of the risk of lead infection and whatnot. But really good early evidence for neurostimulation now. What Sheffield did 20 years ago, now on scale with better technology. So some some relief for our patients, but we're no way close to understanding that fundamental, what is driving that pain, so that we can really target it very well. If I have 1 second, there are some companies, including GSK, now coming up with monoclonal antibodies to nerve growth factors and certain other neurofilaments. I think that might be an interesting area for neuropathic pain, but the field of diabetic neuropathy is still neglected. And all of Jonathan's efforts has been to make sure people get screened for insensitivity of feet rather than diabetic neuropathy. Advanced neuropathy so much that one can't feel the foot, which puts them at a higher risk for getting diabetic foot ulcers. And that's where we have concentrated our clinical efforts at. But you don't get there without having anything, the day before. This happens over a long period of time. And we still don't know what we need to do as a good test here and how we can prevent that from going there. So that's where I stop.
That's a comprehensive answer, isn't it?
Fantastic.
What about if we prevent diabetes from happening in the first place? We've got 1.3 million people with pre-diabetes now referred into the NHS diabetes prevention program. Will that prevent peripheral neuropathy?
I don't think it will prevent all of it, partly because I think there's a lot of neuropathy occurring in even a pre-diabetic stage. There's a metabolic component, but I think you will probably prevent the advanced insensitivities. Your amputation rates will really go down. You'll have, neuropathy that may cause you distress, and you'll have neuropathic phenotypes that we'll have to manage. But you may not have people walking around to your clinic happily with an ulcer in that shoe. That will not happen, I think. You'll do very good. I think that is really the way forward, is to prevent diabetes.
Very good. Fatima, anything on ulcer prevention in people who have neuropathy? Different elements to prevention, aren't there?
Yeah, they are. And I think it starts with checking feet daily and immediately seeking help when you actually notice something. And I think patients need to be reminded about this constantly, because in as much as they might be attending a foot clinic for years, when they do develop a problem, it might take them 3, 4, 5 days before they actually decide to do something about it, because initially they think it's not that serious, or it's okay, or it won't progress, or they can self-manage. And I think good footwear, so it's a sort of patient, I think it does, in as much as we talk a lot about patient education, I think it also stems around physician or healthcare professional education, because our healthcare professionals need to also recognize problems in patients with diabetes, particularly around feet. And the sooner they refer to specialist care, the quicker we can get on top of things. There was only one other thing that I know we didn't touch on, and that was on the charcoal foot, but it's a whole other topic.
Gosh, that could fill another hour and a half, couldn't it? So that's a much rarer complication of peripheral neuropathy, which perhaps will... David, prevention, so you found someone, you've done a sort of screening thing, you found someone with neuropathy who neither you or they knew they had it before. Anything around prevention of painful neuropathy that you're aware of?
Nothing really.
Nothing. No. Fair enough. Okay. Now, we've had a lot of talking. Julia, either what do we need new from what you've heard tonight, or what are you aware of with your JDRF hat or other hat on that may be going to change the field, or that would... So what are the new innovations, either that we need or that we've already got emerging?
It depends on where you look in the pipeline. Obviously, with modification of type 1 in terms of disease prevention or delaying, there's lots of new stuff out there. How far that's going to go, no one can actually say yet. There's some great things. But one thing from listening to the conversation is we're always talking about what workshops do we need to try and help define research questions so that we can provide some funding. And it really does sound like, to me, there's a big gap in perhaps disease modification, and of course how do you actually, what sort of biomarkers could we use, maybe a little bit earlier than symptomatic.
For picking up the diagnosis.
Yeah.
So that is a big error. I agree with you. I think, I think we've all got experience where we've seen someone with a neuropathic foot ulcer, and you look and they were assessed by a consultant colleague or a practice nurse or anyone, and it says foot examination normal, but it can't be normal because they've got a neuropathic foot ulcer. And so anything on the horizon? Anyone? New diagnostics?
To be quite honest, not that I'm aware that we're talking enough about. I think it's, we're always looking for what are the next areas we should be investing in. And to me, this really sounds like something we should be having more conversations.
Nice.
If we all
Here we are. We've just lobbied JDRF.
You certainly have.
I think this
You
is.
certainly have.
I think we really need some more focus, because if you take all of us and examine one patient, we will come with a different sort of examination result. If you're doing their motor reflexes, hot and cold tests.
So yours and my results
I
would be
think
exactly
will
the
be
same?
widely different. And I think this is where perhaps the neuropathy element has lagged behind. Like you said, with eyes, we have cameras that tell us exactly what's going on. Even the kidney people have a urine protein that they measure, and they can see it going up and they can see it coming down. And we don't have such simple tools by the bedside that we can measure if it's wrong or not, but then can't, even if we have something like that, I don't know whether it can tell us if it's going up or coming down. So we don't have a sort of biomarker. And that's caused a lot of problems, because that has impaired the development of good drugs, because you don't know if the drugs are failing because they're not measuring it correctly or they're just not working. So it's a huge element, and it's a very tricky area, and we are really limited by a good, reliable, accurate biomarker. And that explains why your patients, our patients, not yours, but ours, have only 65%. It's difficult to do these and clunky and cumbersome.
Okay, so question. We do retinal screening. It's accurate, precise, reproducible.
Yeah.
I have it in my head that if someone's got diabetic retinopathy, that if I look hard enough and invest enough money on various tests, I will find a peripheral neuropathy, because the two go hand in hand. So have we not already got a good marker for the presence of peripheral neuropathy?
As in retinopathy itself?
It's the presence of retinopathy.
Right. Yeah, and I also feel and the Sheffield model has shown that using that retinopathy event, when they present there, is 95% of the time, they
there was
go
neuropathy as well.
Yeah. Also, it's a good time to check for their neuropathy, even if you're using, because you have a patient who is there for their retinopathy check. You get a one-stop assessment.
Don't go down that route.
No?
It pains me. No, please.
Yeah. So
you wouldn't believe how many retinal screening centres do not have an extra room for a clinician to
I
examine the foot.
Yeah. I just said that from
which is why my heart
from the
sinks
simplicity of it. And we've tried that in South London, and I couldn't get that off because of the rooms. There is no space.
Exactly. And that's the case nationally. So I don't think that's something that we can operationalise. Julia.
So I'm just going to ask a question, right? And it might be a bit out there. So one of the things that, obviously there is a bit of a concern at the moment is people with certain degrees of retinopathy being offered and going on closed loop systems, because the improvement in HbA1c seems to drive a progression of retinopathy, or, I think there's more research going on that to prove that, but I think the guidance has changed in the last few weeks about who's going to be offered closed loops based on retinopathy diagnosis. Is that also true? Is anyone looking in the neuropathic space that people going on closed loops, is that going to change for them?
So it's not closed loops per se.
Yeah.
It's rapid improvement in sugar. So if
But-
your HbA1c comes from the stratosphere down to a very reasonable value within weeks, it has been well recognised for decades and decades that you can get, if you've already got retinopathy, you can get acceleration of progression during that correction phase. It's also said that people can get more pain during that, in terms of neuropathic pain during that phase as well. So if that answers your question. So it's not a feature of closed loop specifically, it's anything that
it's
will
just we may be
bring
getting a
it.
huge group of patients.
But I mean, in terms of how many cases where I've seen progressive retinopathy due to speed of reduction in HbA1c, these are small numbers in what is increasingly a long career now. I don't know, let's pick someone. Robert, decades of experience. Is this common? How many, is this something you can count on one hand?
I think I would say it's pretty uncommon.
Yeah.
I've certainly seen painful neuropathy get worse with rapid improvement in control.
Yeah,
I think that's quite well recognised.
Yes, no, absolutely. But in terms of that, sight-threatening retinopathy occurrence because of speed of correction, sort of thing you can count on one hand.
Very
in a career.
unusual, I think. Yeah.
Does that help?
Yeah.
So I just want to add a comment to that. I think you're right, because one of the things we have at King's in the last few years is been the initiation of a national diabulimia service, where we're having young people, mainly with type 1 diabetes, some type 2, predominantly women, being referred with eating disorders of diabetes. And they usually run their HbA1c since 11-12%, just ketones of 1.8, but never 2, so never get admitted. But they go through the process, and sometimes difficult to predict which of them drops their blood sugars too quickly, but many of them drop their blood sugars. Very few of them get severe pain, but they do, and I end up seeing that the crashing sort of treatment-induced neuropathy and neuropathic pain. But I've not had anybody in that group whose eyesight has deteriorated to a threatening level with that improvement. And we have about 71 patients in that group. We are very interested in their autonomic function, because many of them come with a diagnosis of POTS now, pre-existing. But we're sort of looking into, is it truly POTS, or is it truly a cardiac autonomic neuropathy? But I'm sort of going on a fun tangent, but we've seen a lot of neuropathic pain, but haven't seen devastating eye disease. But yes, a deterioration in the eyesight, on the retinal screen nominally, which then stops and then continues to improve.
Yeah, thank you. How about that as an answer?
Very comprehensive.
Okay, let's move to alleviating the burden. There's two aspects to this, isn't there, which is articulated on my crib sheet. Alleviating the burden for people living with peripheral neuropathy. Can we do more? Should we as a health system do more? And there's actually alleviating the burden for the health system itself, which of course is increasingly under pressure and capacity issues in primary and secondary care. Well, Fatima, you're sitting there with a microphone, so you have to surely take that on first.
I looked away, That's not true.
Or, mind you, we haven't heard, or David, because you're about to embark on a big qualitative piece, aren't you? And so tell us about the burden of living with peripheral neuropathy. What should we be doing more for people?
Some of the themes that come up from what I've read so far and from the conversations I've had is feeling a little bit left alone. So the sense that doctors don't diagnose or don't treat. Sometimes, and we've heard that today, because there aren't that many effective options. Sometimes because it's a bit of a Sisyphus game of, and multiple morbidities can be a difficult patient potentially as soon as you start opening that box of Pandora. So something in the system that can accommodate that, or at least acknowledge the fact that there is a burden of suffering. So that's within the system. And then maybe there's scope for self-management, better education early on, around prevention, as we've touched on. You've also talked about diabetes prevention as such. The prevention program is certainly in the pre-diabetic spectrum interesting. I think you could even go a step further and say it's in a subgroup of people, a political, socio-economic issue, looking at determinants of health, to say that there is an environment we live in, and things like air pollution and nutrition and educational levels do lead to a higher risk. So that is primary prevention that shouldn't be solely in the realm of clinics and researchers. It needs to be a political issue, I think. That'd be interesting to hear from you what the discussion is around that. So that'd be
I think we do desperately need more qualitative work in this space to appreciate better the real concerns of people with lived experience. And I know you've got money to do that now, David, and I'll be working hopefully with you on that.
Yep.
So, but I'm going to turn to the audience now, because I've just looked at my the clock on my phone and realised that we need to be having more open debate with the audience. So may I open things up? I think we've covered lots of ground there, including thoughts for future, etc., prevention. So we've covered a huge spectrum of stuff there. Who's the first hand in the air? Second row and then first row. And I then have to... Will the Slido questions appear in front of my eyes? Or, aha.
A little bit. Can you hear me?
Yes.
A little bit out of left field. I'm an osteopath as well. Recently retired, but the bulk of my practice was treating patients with chronic pain. So these are people who've been in the rounds of doctors, other osteopaths, chiropractors, acupuncturists, you name it. What I use principally as my conceptual approaches is two of the models which the World Health Organization used to describe osteopathy. Is a 5-model description, which is a biomechanical, which is open to any connective tissue in the body. It's not musculoskeletal. So it can be membranous, big serous membranes, visceral, and so on as well. Vascular, neural, they all have biomechanical properties. Second, respiratory circulatory, and this touches on ischemia and congestion, and therefore the pain consequences of those. And the major driver of the return circulation being the respiratory diaphragm. Third, neural, and this can be the integration of the entire autonomic and somatic neural systems. And fourth, the energy conservation, and fifth, biopsychosocial, of which we're all familiar. I use the respiratory circulatory and the as a very important model. Any dysfunction of that, as I indicate, leads to congestion or ischemia in either globally or locally, depending on where the restrictions in the body are, the dysfunctions of the somatic or visceral nervous systems, connective tissue systems. And this touches on some of the things that you've all been saying. So in terms of diabetic neuropathy pain, yes, there's a fundamental pathological condition, but there's also all the associated dysfunctions that can perhaps be alleviated. And so I see diabetic neuropathy as a subset of the general chronic pain problem that is around the whole of the population. The other is looking at the neurological model. Any dysfunction anywhere in the body will create afferent drive in the neural system. That may be sub-threshold, but when it accumulates, you can take it over threshold, and it can be in strange places as a consequence. because the cord is not segmented. So my approach has been to find wherever in the body there is mobility dysfunction, and also to give a lot of emphasis to improving the global and local circulations. And I just pass that on as modifying factors for this, the kind of problem that
Yeah, well,
Julie
thank
mentioned.
you. Fascinating insights. Thank you very much. Let me take a couple of other thoughts, comments or questions before turning back to the panel.
Given that GP is not very good at screening for neuropathy, should the patient be encouraged to demand an annual neuropathy screen from the GP?
Should the patient be encouraged
To ask for it.
to ask
year.
for it?
Yes.
Yeah. Yes, I mean the pull-push side of this is something that I think we and third sector colleagues, JDRF and Diabetes UK, have been big on in terms of empowering people to know what to expect every year, and if it doesn't happen, to ask for it. That tends to gravitate towards be most useful for those with the greatest personal reserve wherewithal. And so it won't necessarily have as good a result from more vulnerable, deprived parts of our communities than the sort of articulate, well-educated, better informed part.
Yeah, it's a huge issue.
Yeah.
We have, when you look at any of the surveys and this sort of thing, reaching out and getting to the disadvantaged.
Yeah. Yeah.
Is really difficult, and
Yes.
I think everybody struggles with it, and it's something we're desperately trying to improve.
Yeah. But apologies, I state the obvious for a GP, I guess. So, other, yes.
Excuse me if I'm showing my ignorance or my deficiency in medical care. Diagnosing neuropathy is a problem, as we've mentioned. 3/4 of them are painless, and downstream problem of the foot ulcer and amputation usually happens for younger generation who are walking, working, etc. There are very high profile, highly visible national campaigns for the heart and the brain. People take notice of it. Time is muscle, time is brain, whatever. There is no visible national campaign to tell people, patients, healthcare professionals, families, that this is something you need to seek help straight away. It pains me when I see our own patients who comes to our clinic and we've given them all the information. Few years down the line, they come back again. When did you have it? 2 weeks ago. What did you do? I went to seek help somewhere and it was getting better. I mean, it just is downhill constantly. And I feel we are having a fight which we've already lost. So a question to you as the national lead.
Not anymore.
Well, you are to me. Why can't we get this into the conversation where it matters?
I think we've had a big push and additional investment, 50 million over the last 6-7 years, over and above the local commissioning of services. There have been big pushes, actually, around the foot attack and things. May I introduce a slightly left of field concept here, which I personally believe is important and contributory, interesting if others agree with me. But I think when you de-innovate a part of the body, such as the foot, in other words, the brain gets no messaging of the foot, people don't see the urgency and same degree of panic, concern when they have a problem with that part of their body, because the brain isn't being messaged that it's part of the body. And many of us who've been working in the field for years and years have anecdotes of, the multidisciplinary team walking into a room and all going, and the patient there with his newspaper, all right, doc, all right, and you think, can you not see the severity here? This is really worrying. And I think there is something that provides an additional barrier to what should induce more concern on the part of someone with very, very severe neuropathy, because their brain isn't necessarily recognizing it as self. in stroke, we often use the term sensory inattention, don't we? You lose that side of the visual cortex and you just ignore everything that side of your body because your eyes don't receive, or your brain doesn't receive information from the eyes from that side of your body because of the stroke. And there is some analogy, I believe, with peripheral neuropathy. Do others share that? Yes? So
it's certainly our experience, isn't it? And also it's your experience too, isn't it? Well, yeah. But I would really think, and I often do wonder whether the second, third decade of living with diabetes, you're getting all these complications, and there is a true neurodegenerate, element like you would have with some other conditions that transfers on, and you lose the sort of, there is no peripheral signaling anymore, and therefore there's an inattention, like you say.
Yeah.
I think there is still a small personality component despite all this in some of our patients. And very interestingly, in diabetic foot conditions, we've never had a good education reinforcement study successful. I don't know whether that is because we've not done the right study, or the brain after some time just can't process. And very senior people like Solomon Tesfaye say, oh no, education doesn't work. But is that, I often wonder, is that because there comes a threshold point, an inflection point, after which education doesn't.
Because of the sensory inattention.
You can't process, you can't process.
Yeah.
I don't know what you think.
Well, definitely there is a psychological element.
Yeah.
Personally, I don't know, honestly, but appreciating a problem, understanding the risks, etc., seems to not just reach the patient. For some reason.
Yeah.
I think on a more practical level, people who don't see very well are not necessarily going to see something at the bottom of their foot or on their feet.
What a good point.
And in actual fact, for a lot of our patients who are not able to get down or not able to bring their foot up, unless they don't have a mirror or somebody else checking their feet, they're less likely to actually notice that something is wrong. And maybe the first time they will actually seek attention is when they start feeling unwell, or they find blood on their socks or in their shoes or something. And I think it's something that we often don't consider.
Yeah, what a good point. Yeah.
Andrew Walton has beautifully shown that.
I've got a fantastic one here. So thank you to, on Slido, Anonymous, for such a fantastic point. Oh, there we are. Great question. May I read it? So, do the panel think that it would be valuable to try and persuade optometrists and retinal screeners to promote or directly refer patients with diabetic retinal disease to podiatry evaluation? Now, we don't do that, and we haven't suggested it ever, as far as I'm aware. Should we?
I think so, yes.
You think so? That's a yes? Thank you. Great question. Any other considerations or views?
I know to be controversial, people will say that who's going to do the screening, but I think any healthcare professional in primary care should be able to do the initial screening. So I think...
For what? For
the initial diabetic foot screening. So if the screeners are not necessarily, who might be from a third party or optometrists on the high street, they should be able to refer to a primary care clinic.
But I suppose this is more... Does the presence of retinopathy, should it automatically, we've got limited capacity across the health service, particularly in general practice, and if that would save 10 minutes of taking shoes and socks off because that person needs to see a podiatrist anyway because they've got retinopathy.
Yeah, I agree.
There's a thought there, isn't there?
I think it would be something that...
Okay, good question.
I think it's mainly because patients are far more diligent about going for their retinal scans than actually having their foot checks. So if, to capitalise on that, patients utilising that retinal service and then to almost catch people earlier, really.
Fair point. Yes. So Vallabhji's brain is thinking, I know the exact proportion of people who never turn up to retinal screening in England as well, I'm afraid. And there is a significant proportion, unfortunately. Yes.
I'm a retired GP. I'm type 2 diabetic. I presented with diabetes with foot drop, and in the workup, hey ho, I had diabetes. We have no podiatry services in our area at all. So I think this is really worrying. It worries me anyway. So you can't refer to a podiatrist because there's nobody.
So certainly we've got pretty much universal coverage for acute diabetic foot problems. You've introduced, this is another fantastic point because no one's mentioned this, but of course the mononeuritis is another aspect that we see in diabetes that none of us have mentioned, which is a single nerve knockoff. Foot drop is a presentation of a single nerve knockoff, and while it isn't ulceration, orthotics can be incredibly helpful there, whereby you have a, what do I call it, Fatima?
An ankle brace or a foot splint.
Thank you. To support people. But yeah, take your point. I think what we've achieved is very good access to the classical diabetic foot complications, but probably not the smaller print complications, and you've just illustrated that point beautifully, I think. But that is another dimension, I think, to neuropathy, diabetes-related neuropathic problems. So thank you.
The podiatry's gone private. You can't see a podiatrist in our area.
Where do you live?
Except private.
Where's that?
Berkshire.
Berkshire. Oh. We're not very. Okay. We can chat on that afterwards. Let me move on. Yes, Sanjeev.
So just going back to that about asking whether retinal screeners should directly refer people to podiatry. We did something similar on a similar theme. So about 4 or 5 years ago, when there was a big drive for assessing renal patients, we on our dialysis unit, we did a little questionnaire saying, firstly, are you known to podiatry? And B, what do you think your foot risk score is? Risk of developing ulcers, low, medium, or high, and do you know how frequently you should be seen by podiatry? And can you say when you were last seen by podiatry? And it's like about 70% of patients didn't know what their foot risk score is, and quite a few didn't know when they'd last been seen by podiatry. And then we were trying to do work with podiatrists so that the renal team could refer them directly to podiatry. And then sort of COVID came along and sort of got in the way. But actually, we're not really sure how much progress we made on it because of the very fact that, do podiatrists have the capacity to see all these people who, these people are high risk and should all be seen every 4 months, every 6 weeks to 12 weeks, according to the NICE guidance. But do podiatry, in all parts of the country have
we got
that level of capacity to see them that frequently?
Yeah, no. So thank you, Sanjeev. Insightful linkage of eye disease and foot disease, which we like. Okay, I'm going to read out this last Slido, and I've just realised as people have headed for the door that we need to draw things to a close. Do we miss opportunities to screen hospital inpatients where we should?
So that was me. It was basically just I'm an endocrinology trainee. It was just a brief point to say. I think we do have very high risk patients in the hospital. Sometimes even when we're clerking them in, it seems we're talking about having a 10-minute opportunity once a year in primary care to screen people, but somebody can be in hospital in a medical ward for 2-3 days, never have their feet examined, and actually we've lapsed into this thing of when patients are being clerked in. I think grossly intact essentially means the patient's not really been examined and stuff like that. So I think we just need to try and get it back up there again.
No, it's a really good point. And Jerry Raymond, diabetologist in Ipswich, who was co-lead of the GIRFT program for diabetes over how many years is that now? 8 maybe? 6, 8? Devised something called the touch test for inpatients with, well, it doesn't have to be limited to inpatients, but very convenient, you know, end of the bed where you just touch the toes and see if they feel that. And but good point. I must draw to a close, I think, now, mustn't I? Are there any, is there a burning issue that I've neglected, or any other really important question that we've...
We can discuss outside, I think,
Yeah.
Jonathan, now. But
Lovely. Looks like we've...
Exactly 8 o'clock.
How about that? We've comprehensively covered the agenda. How's that?
And brilliant chairmanship.
Yes,
and the
great
fantastic 4 here, Julia, David, Fatima and Prashant. Yes? Oh my God. What a great panel. I think we really covered it very comprehensively. And thanks again to Alan Diamond for supporting it. And thank all of you, the audience, for great interaction. So well done, everybody.
That's wonderful.